Okay, we're gonna start the luncheon session. So, my name is D.W. Park from Assam Medical Center. I would like to invite our the panel and Professor David Cohen and Professor Sung-ho Hall, Professor Yoon Seok Go, and Professor Sang-Nok Lee. So, and this session we are learn some recent updated ultra Sapien 3 Ultra valve, and the title is Engineered for the Future. So I would like invite the first speaker and Professor Cha Jung-jun from the Korea University Annam Hospital. His title is Sapien 3 Ultra Multidimensional Analysis from Frame to the Otoscope. Okay, Professor Cha.
Thanks, Chairman. It's my privilege to have opportunity to present this topic with the respected Professor Park as the chair. Recently, Sapien 3 Ultra was launched in Korea. In the United States, Sapien 3 Ultra obtained FDA approval at the end of 2018 and is already in use. In this regard, I'd like to briefly present the difference and comparative study with the Sapien 3 valve. As you may already know, the TAVI procedure is currently a very good option for treatment of aortic stenosis. In addition, Sapien valve series showed good clinical outcome across the partner 1, 2, and 3, regardless of the risk stratification of patients with aortic stenosis. Based on these results, about 500,000 Sapien valve procedures were performed worldwide. The Sapien 3 valve, which has been used the most so far, was first operated in patients in 2012. Until the release of the Sapien 3 Ultra, many studies on Sapien 3 have been published for about 8 years. Among those studies, only Sapien 3 valve is proven superior to surgery in lower risk severe aortic stenosis patients regarding composite of death, stroke, or rehospitalization compared to surgery in up to 2 years. Also, these results show a better result than surgery in individual outcome regarding mortality, stroke, rehospitalization, and bleeding. Even in the permanent pacemaker implantation rate, which is concerned about the valve procedure, Sapien 3 showed a significant Sapien showed a globally consistent single-digit new permanent pacemaker implantation rate. As you know, perivalvular leakage of moderate or higher, which is known to affect adverse clinical outcomes, showed no difference compared to surgery in both 30 days and 1 year outcome. Based on these circumstances, the Sapien valve is expanding its scope to fields such as a bicuspid valve and young patients who require the long durability of the valve and valve-in-valve procedure, and the result showed comparable. Meanwhile, effort to improve the Sapien 3 delivery system continued. This is because factors such as accurate positioning and outer sealing skirt and lower profile are closely related to stroke or acute kidney injury and major vascular bleeding complication. Thus, the goal of the next generation system includes the same Sapien 3 valve on improved delivery system to further streamline the procedure and streamline sheaths designed with a single low-profile sheath for all valve size. At last, the Sapien 3 Ultra system was developed. This system included an on-volume valve design and as well as removing the needs for valve alignment. In addition, the pusher eliminated and reduced the step requiring during deployment with 14 French compatible for all valve size. Afterward, at the end of 2018, Sapien 3 Ultra received FDA approval and the new system seems to be settled. However, a balloon-related problem with the on-volume valve system was reported. The FDA ordered recalled, and accordingly, the existing Edwards command delivery system was used continuously. Due to these happening and complicated licensing problem in Korea, Sapien 3 Ultra can be used in Korea after about 3 years after FDA approval. To this end, Dr. John Webb visited Korea last month and introduced Sapien 3 Ultra through the launching symposium. The left is the Sapien 3 Ultra and the right is the Sapien 3 valve. The most basic component of the valve, including frame with cell geometry, bovine pericardial tissue, and inner skirt, are the same for both valves. The difference is outer skirt, sealing skirt portion. The Sapien 3 Ultra valve increased the outer skirt height by about 40% compared to Sapien 3. Also, texture and outskirt material is designed to add in sealing. It brings effective reduction of perivalvular leakage compared to the Sapien 3. So in summary, you can see that the same equipment is used, including the command delivery system and E-sheath introducer sheaths set used in Sapien 3. The difference is that the outer skirt of the Sapien 3 Ultra valve is high up to 50% of valve height with a different texture. Regarding the procedure process, since the valve sizing and orientation confirmation and nominal inflation volume and the valve alignment process are all the same as the existing method, it is easy to adapt that the operator will hardly notice any difference from the previous procedure. So, in terms of clinical outcomes, what does the difference between Sapien 3 Ultra and Sapien 3? I show you two studies later, of course. As the valve is improved, moderate or severe PBL showed 0.8% incidence in Sapien 3. Moreover, Sapien 3 Ultra valves show a lower PBL incidence of 0.5%. This is thought to be the effect of the upgraded outer skirt texture. First, let's look at the result of the retrospective analysis of about 40,000 patients in the TVT registry who underwent TAVR with the Sapien 3 or Sapien 3 Ultra between January 2019 to February 2020. After exclusion of the patient with alternative access and valve-in-valve, non-elective TAVR, propensity matched analysis was performed in one-to-one matching for the 27 covariates. Echocardiography and clinical outcome at discharge and 30 days were compared between matched Sapien 3 Ultra and Sapien 3 patients. In matched data, there was no statistically significant differences between the baseline characteristics between the two groups, and the patients were about 80 years old and had intermediate surgical risk in terms of STS score. There was no significant differences between the two groups in echo parameter. There were no difference between the two groups in conscious sedation and also valve size. However, the procedure time and fluoroscope time showed a lower in Sapien 3 Ultra. Maybe it can be explained that the on-balloon valve type of the Sapien 3 Ultra delivery system had benefit from the fast procedure. Anyway, now they are recorded by FDA. So regarding in-hospital outcome, most of patients were discharged with 2 days, only 2 days. And most of the patients were discharged, and the length of time of ICU did not differ between the two groups. Regarding PBL, there was no difference between two groups regarding the moderate PBL or severe PBL, but the mild PBL incidence was less in the Sapien 3 Ultra compared to the Sapien 3 with its statistical significance. And as expected, other individual clinical outcomes showed similar results expected for any readmission. The clinical outcome of this retrospective analysis are comparable to Sapien 3 Ultra prospective multicenter studies and presented in London. Also, the similar trend was shown regarding the PBL rate. Another study is a meta-analysis comparing Sapien 3 and Sapien 3 Ultra. A total of 8 studies with about 4,800 patients were included. And the mean age is about 80 years old, and male sex is 48.8%, and the mean STS score was 4.4. The primary endpoint was all-cause mortality, and secondary endpoint is stroke and major bleeding, permanent pacemaker implantation, and PBL. So there is no statistically significant difference between Sapien 3 Ultra and Sapien 3 with respect to all-cause mortality, and there was no statistically significant between Sapien 3 Ultra and Sapien 3 with respect to stroke and bleeding and pacemaker at 30 days. However, with respect to PVL, Sapien 3 Ultra was associated with a significant reduction in both mild PVL and moderate to severe PVL compared to the Sapien 3. And our center, Korea University Anam Hospital, a case with Sapien 3 Ultra was performed for the first time in Korea with Dr. John Webb. Afterward, the number of Sapien 3 Ultra cases has been increasing through the TAVI procedure. Although it is a very small sample in our center, the PBL incidence seemed to be much lower compared to the recent performed Sapien 3 valves in 10 cases. Of course, we should see more Sapien 3 Ultra cases for judgment of PBL incidence rate. So here is a summary. Now, we have new advanced weapon to treat aortic stenosis in Korea, in Sapien 3 Ultra, with the same system and same procedure, but more advanced to reduce PBL by upgrading outer skirt. Thank you for your attention.
Okay, thank you, Professor Cha. So, end of 3 consecutive lecture, we will have enough discussion time. Okay, and next lecture is lifetime management. Start with the first valve choice, and Professor James Flaherty from Northwestern in United States.
Thank you, Dr. Wu. I have nothing to disclose, but this is a sponsored program, so it's going to focus on the Sapien valve. So particularly in low risk and younger patients, as we've been talking about all morning, we have to think about what's our first choice of treatment. And this impacts mortality, stroke, aortic regurgitation, conduction issues, and coronary reaccess. We're all familiar with the evolution of TAVR, starting in inoperable and high-risk patients compared to surgery, and then moving towards intermediate and finally low-risk patients, and all the seminal publications that accompany this journey. And the latest data shows that TAVR in low-risk patients has become very, very safe, with very low 30-year mortality, very low paravalvular risk, with the Sapien 3 and now the Sapien 3 Ultra valve. And here's some of that low partner 3 low risk cohort data, again showing very low complications and very low mortality following this. And not surprisingly, in the United States and in emerging markets, TAVR has become the predominant form of treatment for aortic stenosis. Yet the age of the patients treated continues to fall as we get into lower risk patients and other populations like bicuspid aortic stenosis. The patients are going to start younger, so they may outlive their valve. So some considerations for the younger patient. Risk of heart block, need for a pacemaker. Left bundle branch block goes into there too. Coronary reaccess for those with coronary disease. Valve durability is a big issue. And lifetime management of the valve itself. Should we do SAVR first, and should we do TAVR followed by SAVR, or should we do TAV and TAV? And we'll talk about those issues. Again, thinking about this as lifetime management and not just a single treatment decision one time. And there's a lot that goes into this. Some of these issues are age and life expectancy, coronary artery access issues, valve morphology, all the things that are going to help you decide what to do for the first treatment. Now, when TAVR started, life expectancy of inoperable patients was probably less than 5 years. One valve is likely more than sufficient. But when you get into intermediate low-risk patients who may have a 10 to 15 year expected survival, they're likely going to need a second valve. Now, if you creep down to even younger patients, we talked earlier about some patients insisting on TAVR, even though they're low risk for surgery. you could be getting in a situation where a patient might need a third valve during the course of their life. So this definitely has to be discussed as part of the heart team, and really considering what are we going to do next, not just the first time, but what do we plan to do next in treating the patient. The low-risk data on the Sapien valve, as we said from the PARTNER 3 trial, is excellent. The data on the self-expanding is also very good. There are some slight differences, certainly in terms of mostly pacemaker rate, and 1 year as well. But maybe there's a little bit of difference in paravalvular leak and certainly in pacemaker rate. So these are things to consider when you make your first valve choice. Paravalvular leak matters, at least in terms of anything more than mild is going to correlate with increased long-term mortality. Most of that has been eliminated with modern valves and very effective sealing skirts. Pacemaker in a young patient probably matters long-term for long-term morbidity and maybe even mortality, but you can see that pacemakers are associated with an increased long-term mortality and an increased risk of hospitalization, particularly if a patient is going to become pacemaker dependent. We know that's associated with long-term RV failure, tricuspid regurgitation. So if you can avoid the need for a pacemaker, particularly in a younger patient, it's an important factor. And you can see that in the balloon expandable Sapien 3, pacemaker rates have become very low, and they're really creeping close to the expected rates with surgical aortic valve replacement. There used to be this big discrepancy when we counseled a patient on surgery versus TAVR, mostly regarding the risk of needing a pacemaker, and now they're quite similar. Single digits is most. What about coronary disease? Every time you move to a younger population, particularly those with valve disease are also going to have high rates of concomitant coronary disease. We saw that in some of our cases today. And if you're young and have coronary disease, there's a good chance that you might need future coronary angiography. At least a third are going to need an angiogram within 5 years of their TAVR valve. What are the risks associated with re-access to the coronaries? Certainly the sinus dimensions of getting into the coronary ostium, the implantation depth, and a self-expanding valve. Self-expanding valves have been associated with much more difficult coronary re-access. But it needs to be individually considered too. And here's some cartoons that show pretty straightforward coronary re-access and then more difficult based on a higher implantation or a very narrow sinus, STJ. So this is stuff that has to be considered, and it's also going to be important in terms of what are the TAV and TAV options. What's the anatomy like? What are the sinuses like? What are the heights? All this has to be now considered. What are the commissure alignments? There's a lot that goes into thinking about the first treatment with first valve choice relative to the lifetime management and what's going to be next for an individual patient. With regard to coronary intervention, at least in the U.S., at least half our patients that undergo PCI after TAVR, it happens at a non-TAVR hospital, so we can't assume that the local doctors are going to be experts at re-accessing coronaries in a patient that's already had a TAVR. Those that have done this, regardless of the valve, know that it can be very challenging to get in and perform PCI in certain patients that have already had TAVR. And again, the emerging data with Sapien 3 has shown that it is easier to access and cannulate the coronary arteries in most cases. CT can be used to help predict that risk of coronary obstruction or coronary blockage by a TAVR prosthesis. Sapien 3 in general, again, versus some of the other valves that are available, has had the most reliable coronary re-access. What about surgical explantation? This is a thing that came up this morning. Some of the lectures and live cases. The data's not great in the explant TAVR registry. There are about 300 patients, And there was a 12% in-hospital mortality. And here you can see with this depiction from a different study, this happens to be a self-expanding valve. These are really complex operations, very high risk. And in this registry, the one-year mortality was approaching 30%, and the stroke rate was approaching 20%, very high. So we can't just assume that putting the TAVR valve in and then expecting a surgeon to rescue us in 10 years is going to be the right option for everybody. What about TAV in TAV? Well, there's some emerging data that in appropriate anatomies, this is a very good therapy. And this is an analysis that compared TAV in TAV with valve in valve TAVR, or TAVR in a previously placed surgical valve. And in carefully selected patients, TAV in TAV works similarly well as valve in valve TAVR. Now, I'm not sure if this data included fracturing of surgical valves, something we saw in this morning's live case. But in the data that we have, the gradients that are achieved with TAV and TAV are lower than those historically have been with valve and valve TAVR. So in appropriate anatomy, it seems that good clinical results can be obtained with TAV and TAV. What about valve choice and results with TAV and TAV? On this graph, I think it was shown in a different lecture earlier this morning, we can see that regardless of the first valve choice, the results tend to be very good with TAV and TAV. Now, again, this is a very selected population. The data that's emerging suggests that balloon expandable valves have a much higher chance of being able to do a TAV and TAV and not risk coronary obstruction or sinus sequestration. And commissural alignment goes into that. It's a little easier to accomplish that. And what about the second valve choice? Well, it seems that both valves, both balloon expanding and self-expanding, work quite well as the second choice of valve. The balloon expanding valve will give a more high likelihood of a lower gradient. But again, you can only get to that point if you have an anatomical option for a TAV and TAV. Bicuspid is an important population that we've talked about in the last couple of days with burdens of calcium and fused raphe. And I think Dr. McCarr covered this morning, showing that the more fused raphe that you have and the more calcium burden you have, the more paravalvular leak you're going to have and worse outcomes. Both valves, both balloon expanding and self-expanding, have been used successfully in bicuspid, particularly with latest generation devices. Whether there's a head-to-head comparison, I can't really say at this point. Certainly you have to be considerate of risk of annular injury with either a balloon expandable valve or ballooning a self-expanding valve that didn't fully expand. So that's a very important consideration in bicuspid patients. Here's some data from looking at low-risk patients, TAVR versus surgical AVR, and TAVR performed very well in bicuspid patients according to this match registry. I mean, there's even a signal that it was better in terms of mortality versus TAVR. Here's the Partner 3 bicuspid registry, about 150 patients, average age of around 70. We see excellent results. These are highly selected. Only about 60% of patients screened made it in the registry, but very low, no death, in fact, at 30 days, very low stroke, very low paravalvular leak, and really hemodynamic results that were equivalent on this graph at 1 year to those that had tricuspid aortic stenosis. So in selected patients, the Sapien 3 works very well. And I'll end on a little bit of echo stuff, which is not my favorite topic, but there's always a little bit of difficulty in interpreting aortic valve gradients post-TAVR, particularly with the balloon expandable valve. We saw today that our cath gradients tend to be very low, and then the echo can sometimes be higher gradients than cath, which doesn't make physiological sense, and some of it may be due to flow patterns, laminar versus turbulent. And the true relevancy of this, I think, is something that still needs to be borne out. Gradients do matter, but to what extent this is echo phenomena versus clinical importance, I think still hasn't totally been elucidated. So in summary, we have to consider, particularly in a younger patient, if we're going to treat them with TAVR or with surgery, we have to understand what the life trajectory of that patient is going to be. What's their necessity of coronary angiography going to be? What are the risks of needing a pacemaker? And what is their next choice going to be if they're going to outlive their first valve? Thank you.
Thank you. Thank you, James. It's a very nice lecture. So we move to the third lecture, and Professor Jungmin An, and the minimalist TAVR, achieving great TAVI efficacy and optimal patient outcome.
Thank you, Dr. Bach. I'd like to share our experience of minimalist TAVR. So what is current status of TAVR? So after the low risk population TAVR randomized trial, so the low risk patient meta-analysis showed that definitely TAVR showed a lower risk of all-cause death and cardiovascular death compared with the SAVR. So after the ACC 2019, TAVR won over the SAVR. So FDA approved the TAVR for the low-risk population. In addition, recent ACC-AHA guideline recommend the TAVR as a class 1 indication for indicated patient. So today, I think the TAVR has become a routine procedure in many cath labs around the world. So course sedation or local anesthesia, less than 1 hour procedure, mortality is less than 1% at 1 month. So what is the difference in our heart center? Recently, TAVR cases rapidly increasing. Last year, we did 250 cases per year. This year, we are expecting that around 300 cases per year. So in our centers, we predominantly implanted the balloon expandable device instead of a self-expandable device. 71 is Sapien 3, the 11% is Sapien XT previous version. Among the 1,000 patients, the mean age was 80. The ST score is 4, low to intermediate risk population. So the device success is 99%. The complication seems very low. Permanent pacemaker rate is overall 7.4. Significant p-value is 3.9. So instance of PPM would be very important in our center. The core valve is 26, but the recent Sapien 3 is 7% single-digit instance of permanent pacemaker implantation rate. The 30-day mortality is around 1.3% in overall our TAVR registry. Disabling stroke is only 0.9. So the 30-day outcome in 2020, the 1 month mortality, cardiac mortality is only 0.6%. One patient died in one month. The 1 year outcome is cardiac death is only 2.4. Stroke rate is 1 year is only 1.6. Very low and very safe procedure, the TAVR in recent year. So in IMC all population from the 2010 to 2020, the overall all-cause mortality at 1 month is 1.8. Stroke is 0.9. Major vascular complication is 3.5. Pacemaker implantation rate is 7.4. PVL is 3.9. But 2020 mortality 1 month is less than 1%. Major stroke is less than 1%, 0.6. No vascular complication. Permanent pacemaker implantation rate is still single digit, 6.6. PVL is 1.8. So we have a good heart team discussion with the surgeon and interventional cardiologist and the echocardiologist. We have a good heart team. In addition, we applied the minimalist approach several years ago. So we also have a very dedicated CT personnel for the CT algorithm for device selection. So in our centers, during the TAVR procedure, we didn't do general anesthesia anymore, except in a very special situation, and no TE. So 30-minute procedure, no Foley catheters. CCU stay at one day, and the day after CCU stay, patient go up to the general ward and discharged 1 day after. Discharged day 3. We have a cardiac rehabilitation program. So since 2017, we increased number of the cautious sedation, MAC, minimalist approach. Well, you have to know that at that time point, we already did the 100 cases per year. So I like to say that after sufficient accumulation of experience, we could do the minimalist approach. So compared with the two period, the general anesthesia period, the conscious sedation period, patient age is insignificantly increased. The comorbidity is also a significant difference. So in some point between the conscious sedation and general anesthesia, but valve characteristic is not that different. But procedure outcome is significantly improved. Device success is improved. The device associated complication is decreasing. 30-day mortality death, cardiac death, the conscious sedation is only 0.7. The general anesthesia period is 3.3. Disabling stroke is 0.7, and other complication is getting decreased. So in our minimalist approach period, all-cause mortality at 30 days only 1.0, major stroke is 0.7, major vascular complication is 0.8, permanent pacemaker is just one single digit 6.3, p-value is 2.1. So in 2022, TAVR is a routine practice in our centers. Patient admit and procedure, and 1 day stay in the CCU. Next day, the stay at the general ward, and the day after the general ward staying, the patient usually discharge. So we try to the same day general ward transfer in patient with a low risk subset. Patient under the age 80 years old, normal ejection fraction, tricuspid valve, calcification volume is 800, no conduction disturbance. In this case, sometimes we transfer patient directly to the general ward without staying CCU at 1 day. So minimalist TAVR, careful patient selection is very important. So in addition, dedicated procedural technique and post-procedural care are the key to success. If it was done appropriately, minimalist TAVR can provide the clinical and economic benefits. Thank you for your attention.
Thank you. So we have enough discussion time. Any comment or any question for the lecturer from panel?
I'd like to ask Dr. Prati, to James. Thank you for your informative lecture. So I'd like to ask, because of we considered several factors to selection of our first valve in our lifetime in AS patients. So what is the most important two factors in your practice for choose the first type of the aortic valve?
Well, I think the most important factor is age and life expectancy. And if that's not an issue, if they're 85, then you go with the valve you're comfortable and what do you think you'll get the best clinical result with. But if they're a younger patient and you anticipate they're going to need a second valve, then it really comes down to anatomy. And what is that anatomy going to be best for not just the first valve, but for the second valve? And that decision may mean surgery is the first thing they do. If they have a tiny annulus and you're going to get a 20 Sapien or a 23 Evolut in, and you've got a good surgeon that could do a root enlargement. We saw today with the valve and valve, what was that, a 19 millimeter? 19 millimeter valves should not be put in. Mm-hmm. So maybe surgery is your first choice. If you can get an excellent result with the Sapien the first time, and it sets you up for a valve and a TAV later, that would be great. If you can do a balloon expandable the first time and still do a TAV later, the CT will tell you. But if there are warning signs that you're going to have risk of coronary reaccess issues or obstruction or sinus infiltration, well then maybe that's not the best first choice.
Okay, so is that James? I have one question for you. And your last slide, you show some echo-derived pressure gradient, also catheter-derived pressure gradient. There is some mismatch. That was sometimes real issue. And our outpatient clinic after TAVR is a pressure gradient going up the 20 millimeter HD. At the time, we are some concerning. What is our optimal decision making? And some physician is to do CT scan or transesophageal echo to rule out valve thrombosis. And some physician just do another thing. Is I have a discussion for that point. David Wood in the Stanford Hospital, and they are routine practice such like a patient. They admit the patient to measure the real-time catheter pressure gradient. They found 1/3 some different. There is he explained, echo-derived pressure gradient is vulnerable to inherent limitation of baronolication, something like that. How can you manage such like a patient pressure gradient is going up? Patients are little symptomatic. What would you do such patient in our?
So we're all familiar with the concept of HALT or hypoattenuated leaflet thrombosis, and at least in short-term follow-up, it doesn't seem to have clinical significance. But then you get a patient that has a gradient of 30 at a month, and when they left the hospital, it was 10, and you're scratching your head. So the options are as you outlined. You could do some more imaging, a 4D CT scan or a TE to look for leaflet thickening. If you think that putting that patient on an oral anticoagulant may resolve the problem, that's a good option. Or you could do an invasive gradient measure. Sometimes putting the patient on anticoagulation will improve or resolve the issue. But you first have to decide, is this just a small valve in a small annulus, so-called PPM, or is it a new leaflet problem? And I think that's where you get, I think both modalities will get you that question. If the gradient is normal on cath, then there is not a leaflet problem. But if you see thickened leaflets and immobility on either a TE or a 4D CT, well then you've got a physiological problem that the first step to treat would be to try anticoagulation.
If the elevated pressure gradient due to leaflet thrombosis, we changed the anti-thrombotic strategy. In my case, in my opinion, I changed the DAPT to NOAC. However, I don't know how long the maintain the NOAC. How about your opinion?
Typically what we'll do is we'll go at least 3 to 6 months. And then depending on how they're tolerating it. Now the caveat is if you stop the anticoagulation, even if it's successful, it may come back. And now you may be in a situation where you're on long-term anticoagulation, which you didn't want in the first place with the tissue valve. There'll be some occasions where they'll be treated with an anticoagulant for 3 to 6 months, and you stop it, and it doesn't come back nearly as bad as it did. So I think that's kind of the way we think. Can they tolerate 3 to 6 months? And if they can, if it doesn't improve, we'll give a trial off anticoagulation and see if it can be safely withheld.
Usually re-image with CT or just look for a transthoracic echo with a gradient for those?
You know, we don't routinely repeat the CT. We rely on the echo, but you can get fooled by the echo too. But we rely on the patient and sometimes physical exams. Sometimes you hear a murmur, like, well, that wasn't there.
I'm also wondering, is the listening to guideline for patient without the OAC indication, how the current contemporary practice in antiplatelet after TAVR procedure is single or DAP?
So based on the popular TAVR trial, and some of the anticoagulant trials that showed, at least in an elderly TAVR population, going to a strategy of anticoagulation on everyone probably introduces more risk than potential benefit. So the Galileo trial, for instance, was stopped for that reason. And the popular TAVR trial compared DAPT versus aspirin alone in their primary analysis, and they really showed that there's no difference in stroke or valve hemodynamics with aspirin alone. So in an older TAVI population, I think aspirin alone has emerged the standard, at least in the United States. Now you may say, what about a 60-year-old bicuspid that refused surgery? Should you do 3 months of anticoagulation like we often do in our surgical patients? And I don't think we know that, but there's a little bit of disconnect in our practice in the United States on younger patients who get surgery versus TAVR, because our practice in many surgery patients is at least go 3 months of anticoagulation to prevent any kind of subacute thrombosis on the valve. David, what do you do?
I mean, we're, single antiplatelet if there's no indication for something else, if they haven't had a recent stent or, and they don't have an indication for oral anticoagulation. If they have an indication for oral anticoagulation, no antiplatelet, just oral anticoagulation.
And what does your center do for your surgical patients?
Surgical patients, they talk about anticoagulating them, but they don't do it as much as they should.
Ours do it routinely.
Yeah, I mean, that's the surgical guidelines say that, although the data isn't that great.
I think the chest guidelines do, I think there's a discordance in their guidelines because the data's not great.
Yeah, I mean, it's sort of one of these things where again, I think if cardiac surgeons were like interventional cardiologists, they would have studied the crap out of this, and we'd know the answer to that question. That's because that's.
But it's a dilemma that we face.
Yeah.
Particularly in the younger. I don't feel bad in an 85-year-old withholding Coumadin because of theoretical benefit.
There's real risk. I mean,
but if they're low risk,
probably I mean, it's probably a shame at some level that all of the anticoagulant studies in TAVR were done before we started doing low-risk patients, because they certainly
we did them on
bad
live
outcomes
bleeding
we
risk
saw
people.
reflect the protoplasm that we're treating.
But I think I feel comfortable that DAPT is not the answer.
No, I think that's settled. Yeah.
Yeah.
I mean,
Unless they had ACS or PCI, DAPT is not part of the post-TAVR milieu.
No, I think.
Question to the apart from this study, because as you told, some patient, more than half of patient combined coronary artery disease. What is your user strategy? PCI before TAVR, simultaneous PCI, or TAVR after PCI? What is your personal opinion?
That's a great question, because when TAVR first started, we felt compelled to treat every coronary lesion we could because we weren't offering surgery to that patient, or they weren't qualifying for surgery. And now we're being more nuanced. We saw this morning one of the live cases they did IFR and showed that it wasn't ischemic. So I think you have to consider, whatever your valve choice is, what's it going to be like getting back into those coronaries? Do I have a 75% borderline prox LED lesion? If I think I'm going to have trouble getting back in, then I'm going to be more likely to treat it up front. So coronary reaccess, I think, is an issue. Now, if they're having angina or it's clearly ischemic, I think you have independent indications to treat those coronaries. But on those borderline cases, I think coronary reaccess is a consideration.
And we do have one randomized trial. It was completed. The UK trial. It was a small trial. It wasn't really powered for major outcomes, and didn't show a benefit of pre-procedure coronary revascularization. But now David Wood is running a 4,000 patient randomized trial, complete TAVR, to try to answer the question very definitively. But that's all post-procedure revascularization.
Yeah, the limitation of trials like that is that it won't have the lag time when you have to go and recat that patient and get that stent in.
Well, I think that's an emotional choice.
Yeah.
So okay, I have one.
There's some practicality to it.
Yeah. Okay, I have one question, Jungmin, and it would be the last question. Is nowadays there is some booming of a minimalist TAVR approach. Initially, we started the TAVR with the general anesthesia and then moved to the MEC. And nowadays, I saw the Philip Generous reported the same day in the morning time TAVR and afternoon discharge. So is Jungmin nowadays recently tried to alert the TAVR procedure without any, sometimes make scheduling with anesthesiology doctor so difficult. Yeah. So how do you feel is about the alert TAVR procedure? Is it work in the U.S. or something like that? Could you explain alert TAVR procedure?
So alert TAVR is basically what was done in the 3M TAVR trial by David Wood. Meaning No sedation.
No
No
sedation.
You mean just heavy local anesthesia for the pain? And somebody was talking about that yesterday. I don't remember who was describing it in the case. I don't have.
Is there any safety issue? During the conversation, just
I think I think it is probably a good thing. I mean, again in the Vancouver study, they did it in 400 patients. They didn't have problems with it. We do it for PCI. I do think, certainly in our own experience when we're doing the patients awake or semi-conscious, who gets most upset when the patient moves is the surgeon, right? Because they never see the patients move. They gets very nervous about that. The interventionalists, we're used to working on moving targets, but we don't want them to be jumping around during the deployment, obviously. And so I think we have to be a little judicious with it. But I think it will take time, and I think the biggest advantage of doing real alert TAVR, as you call it, is no anesthesia. You wouldn't need an anesthesiologist at all. And for a lot of centers in the United States, and I suppose here as well, anesthesia is a major barrier. There are so many more procedures coming. MitraClip, they all require anesthesia. Watchman, they all require anesthesia. So if we can get rid of it for TAVR, it would be a big help.
Yeah. Okay. Comment.
So I'd like to add it to the one or two things. The first, if we want to do the adult local anesthesia during the TAVR, I think the very experienced operator that have to do such a procedure. The operator can deal with the unexpected situation. In addition, one advantage of the local anesthesia would be the maintaining the hemodynamics during the procedure. Even though the conscious sedation, sedative drugs sometimes decrease the blood pressure, so the local anesthesia may have advantage of maintaining the blood pressure, hemodynamics during the procedure. But before such a procedure, I think you have to discuss with the patient. Patient is very nervous and very agitated. We cannot do that. But the patient is very patient, and then they accept to such kind of situation. Then you are the very experienced operators. I like to recommend the local anesthesia instead of cautious sedation, particularly in case of the limited operating room or the anesthesiologist volume.
So is another intervention kind of concern about seizure risk? Is like some.
During the rapid pacing, patient has some problem with a little bit rigid motion, but not that severe, not that grand mal seizure.
Just a little bit seizure-like motion.
Yeah, a little bit. Compared with.
If you have a long pacing run, that's what we talked about that in our case this morning. Was my own preference if I know I'm going to be doing a valve fracture procedure is to do those under general anesthesia, because the pacing run sometimes can be 30 seconds as you're trying to crank the pressure up, and I don't want the patient to be uncomfortable. So those cases we didn't today, but I normally would.
So I think it's the time limit. We're gonna end this luncheon session time. We move to the next session. Thank you.